over like 2+ millennia, the child mortality rate was about 50% until the middle of the 20th century.
Dr. Bonnie Maldonado is a legendary figure in infectious disease who has served on the front lines of 2 defining pandemics.
Vaccines save lives. In the last 50 years, we've saved millions of hospitalizations and over 1 million deaths.
A vice provost at Stanford University and the Taub Professor of Global Health and Infectious Diseases, she began her career as a disease detective with the CDC during the height of the HIV/AIDS crisis, and most recently helped lead Stanford's response to COVID-19.
We may likely see endemic measles come back in 5 years.
In our conversation today, we'll explore her journey from the daughter of immigrants to one of the nation's most trusted voices on vaccines, the reality of battling polio and misinformation globally, and her relentless fight for health equity. Welcome to Stanford Department of Medicine's Inside Look at the Future of Medicine. Well, Bonnie, welcome to the Future of Medicine.
Thanks, it's great to be here.
We just had an amazing talk from you as part of our grand rounds here, and the title was Lessons from a House on Fire, the subtitle. What did you mean by that? Where did that come from? Tell us about the house on fire.
Yeah, so that was a bit of a double entendre. Part of it was in this era of bombardment by social media. I wanted a title that would draw some attention.
Yeah.
And I also have a very deep commitment to the meaning of that particular phrase because it refers to a book.
Okay.
It was called House on Fire.
Yeah.
And it's the eradication of smallpox. So the book is written specifically about a task, no mean feat, that was given to Bill Foege. Now, Bill Foege was one of the senior and founders of the CDC back in the day, and he did a lot of work in the field. Really, in many cases, people think he's the father of CDC epidemiology.
Yeah.
And he was tasked in the 70s with eradicating smallpox in India.
Wow, that's not a small country.
Absolutely, and I can't think of a better person to do it. But with all of the, first of all, he was successful.
Yeah. Well, remind us though, before we get to his success, but remind us what smallpox is, because that is not a disease to be taken lightly.
Right. So smallpox is not related to, but is a cousin of chickenpox. Okay. And I don't even know if any people know what chickenpox is anymore because we've been so great at eradicating that too.
Yeah.
But it is a disease, it's a viral disease, respiratory and contact disease that you get, and without immunity, you can get these essentially boils on your body. But these are really incredibly destructive and life-threatening diseases because you are covered from head to toe. In some cases, if you look at old pictures, people's entire faces are essentially obliterated by these lesions, and they're just blisters and boils all the way across your body. It eventually can kill you by organ failure.
So the pustules on the skin that then grow and get high pressure and then sort of
they
burst sometimes.
And they can actually cause renal failure because then you can get infections and dehydration. This used to be a major scourge for millennia, and it was 40% fatal. It's a very highly fatal disease. And it's famously known because that's the term vaccine came from smallpox.
Yeah.
Because Louis Pasteur experimented with it, and others did as well. So Edward Jenner back in the day, in the 1700s, realized that milkmaids did not get smallpox.
I see.
And remember, back in those days, 30% mortality, this is a big deal.
Yeah.
And the people who survived were incredibly disfigured. They had lesions all over their faces.
Blindness and
and blindness. And so what he noticed was that these women, primarily women, milkmaids, did not have lesions, but he did notice that they'd get lesions on their hands that looked like smallpox. Okay. And he realized that these were lesions from the udders of the cows, and this was cowpox, which is a different virus, but related enough that you would get immunity. So he actually scraped these lesions, and he actually fed them to people. He fed them to himself first, but he wanted to try a brand new experiment, which is we would not recommend today. He fed these lesions to a 6-year-old boy.
I heard it was his gardener's son.
Yes, his gardener's son. And no informed consent, unfortunately. But when that child was exposed to smallpox, he did not get sick. And the reason they're even called vaccines is because Latin and in the Latin Romance language is vaca,
Yeah.
is cow.
I see.
And so he vaccinated this child.
Right.
And so anyway, so smallpox killed millions of people.
Yeah, and this is over thousands of years.
Over the history of mankind.
40-50% mortality. It's
Yes.
just a horrible, disfiguring disease.
Right, so very fearful of this disease. Now, the interesting thing about measles, and coming back to House on Fire, is that the way you can eradicate, and the way the target was, you did something called ring vaccination, which we don't do very often.
Yeah.
Because one case and first of all, if you have immunity, you are protected against getting infection. Very few diseases will do that. So most diseases, if you get a vaccine, you are immune from serious complications, but you may still get infected.
Yeah.
And you may still be infectious.
Right.
With smallpox and measles, by the way, if you get vaccinated or if you develop immunity, you are no longer able to get infected and you can no longer transmit to others. So that's very fortunate in one way.
Yeah.
And so they use that to their advantage. So what they did is, and Foege and his colleagues decided, and they took a long time to figure this out, but they said, if we find a case, we run to that case and we vaccinate everybody in that household, and everybody in the household's like 2 degrees of separation away. So you essentially vaccinated around a case, so that therefore you would prevent the spread of the disease, rather than the current way we do other vaccinations, which is to vaccinate everybody, because everyone is at probably high risk of getting an exposure.
And the mechanism of spread for smallpox?
It's respiratory primarily, and skin-to-skin contact as well.
I see.
And so his story was talking to the Indian public health agencies, talking to frontline providers. So how do we do this?
Yeah.
And one of his colleagues said, and so he thought, well, how should we do it? They essentially invented ring vaccination this way.
Yeah.
But one of his colleagues in India said, let's not vaccinate everybody. This is a house on fire. If you have one person who's infected, go put out that fire. Vaccinate that person's household and the people close to them, rather than going out to the houses
like
in
a
the periphery.
targeted rather than a sort of
So
herd immunity.
So absolutely. So targeting immunity. Now, let me just be clear, that's not going to work for many of the other diseases. We're very fortunate that it worked for smallpox, and it might work for measles. But we can't do that for diseases like COVID or flu or anything else, because those diseases don't, most people who get infected aren't that sick or may not have symptoms at all. And may be be able to transmit even after they have immunity. So you can't really do that for many other diseases. But that's why I came up with that title.
No, it was a great title, and I think that, many people would believe, students of history, that humanity's greatest achievement may be the eradication of smallpox. And I think, I'd heard that and knew that line, but until I really studied in a little bit more detail, reminded myself, I learned it in medical school, I'm sure, but of just how awful a disease smallpox was, and for how many thousands of years it was killing half the people who got it. I think that then you get the extent. And you had some figures in your presentation just about the child mortality rates over millennia. Maybe talk about that a little bit.
Sure. So in addition to talking about smallpox and House on Fire, one of the things I wanted to point out by that analogy is that we don't remember. We don't remember how fortunate we are and where we are. And again, I'm a pediatrician. I'm a born optimist, but pediatricians tend to be very optimistic. And things are tough right now. But at the same time, we've come a long way, and we need to remind people where we were and where we can be. So if you look at the data that I presented today, there is a slide that demonstrates that over like 2+ millennia, the child mortality rate was about 50% until the middle of the 20th century. So it wasn't until the 50s.
50%.
The 50%. 1 in 2 children died before they were 5 years of age. And that is the history of mankind, of humankind. Not to mention maternal mortality rate, which we didn't get into.
Yes, right. But we're not even a century beyond that moment.
Not even. But in this day of, it's so 5 minutes ago, or it's so 5 seconds ago now, we forget that. And that's okay. I'm glad we don't have to remember it. But we also need to remember that we've done a lot, that these vaccines really have kept humankind alive. And that we can do more, we can do better, and we can continue to build on that.
You showed just a stunning slide with the statistics about the number of lives saved, the amount of money that from the economy that is saved. Yeah, talk a little bit about that.
So again, and I've been to Congress. We've all testified in front of Congress and talked to them about the value of vaccines. Remember, these are people who come from all walks of life as well that are making decisions that affect all of us, and they don't understand, and I don't expect them to. So our job is to come and give them, boil down the bottom line. And the bottom line is vaccines save lives. In the last 50 years, we've saved millions of hospitalizations and over 1 million deaths.
Yeah.
And if you want to put it in financial terms, we've saved over $1 trillion in indirect costs and over $1 billion in direct costs related to hospitalizations.
Yeah.
Just from the vaccines that we use today.
Yeah.
So if you want to look at not only the human footprint of vaccines, but also the societal dollar costs, we're really not only spending money well, we're actually saving a lot of money with the vaccines that we use today.
What is your diagnosis for this sort of idea in society that has grown of a skepticism towards vaccination? We don't have the same skepticism towards chemotherapy or towards immunotherapy for cancer or stent for your heart.
Well, I'll tell you, you and I would beg to differ just a bit. We're already seeing, and I've seen this in my own life, people I know who no longer want to take chemotherapy. They want to do we know some very famous people who did not want chemo, who did not want conventional medicine. And that's always been the case.
There's always been some element
we always have that. And I think that's just part of it, right? There's a spectrum of belief. But I do think that one of the biggest differences between vaccines and all those other things you mentioned is we're talking about healthy people who otherwise would not need any interventions at all. And you've got the heartstrings factor. Your young baby, your little beautiful child that just came into this world, and I'm going to put these foreign substances in my baby's body. One of my girlfriends, who is a communications expert, and she's a colleague as well, talks about this in terms of safety versus risk. So when you talk about safety, let's just say you have two bridges. They're not very well constructed. They're both a little rickety, but you want to know which one's a little bit safer. I want to cross one. So you can put a safety report together. Look at pressure, how likely is this one to splinter, how easily can I cross it, et cetera. So you have that data. You can have a report, and you can say this one's safer, but 30% safer, 10% safer, whatever it is. So you pick. However, if you have a bear running after you, you're going to take whichever bridge is in front of you, whether it's 10% safer or 40% less safe, because you want to get away from that creature. And so I learned this lesson even more during COVID, and I learned it again before that with the H1N1 2009 pandemic. People always weigh, and this is smart, this is how we survive, risk and benefit. And the risk and the benefit is very individual, right? We all look at risks and benefits differently. Everything we do from the moment we wake up in the morning to the moment we go to bed is a conscious or unconscious risk-benefit calculation.
No, I couldn't agree more. And thinking about risk in my case, for my medical practice, sudden death risk is something we talk about a lot. Obviously also heart attack risk, but risks can be quite theoretical in people's minds and making them real and making people, it's hard to say, you have a 1% risk of this complication or 1% risk of this event happening. It's almost impossible for people to really understand that, especially if the timeline is long, like in 10 years.
Especially, yes. And so that's part of it as well. So for example, even in adults, how easy is it to say, you should do whatever the steps are now that you got to do 150 minutes of exercise once a week. I'm going to start off on Sunday, I'll get a little bit in, and then I'll do the rest during the week. How hard is it to really get that done? So even when we know that there's a benefit, the execution is difficult. Now with vaccines, it's a little different because it's very easy. We've made it so easy, but there's a couple things. First, it's the factor of, you're taking healthy people. And actually, the risk of an adverse effect, although they're very mild, the risk of an adverse effect is pretty high. So most children are going to have pain at the site of injection,
Right.
maybe a fever, they may be fussy. I've had it, my own children had all the vaccines, and I remember
Yeah.
people don't like to see their children in distress. And then they look at the benefit. What's the benefit? I haven't seen a measles case in ever.
Yeah.
I don't even know what tetanus is.
Yes.
And so you're talking really for them.
It's almost a victim of its own success in a way.
Exactly. And to them it's hypothetical. For those of us who've been in practice long enough, we know that these diseases are still out there.
Well, measles, since you mentioned it, let's turn to that for a moment, since there are more cases than we've seen in the last many years arising again in the US related to vaccine skepticism and the fact that people are using vaccines less for their children. Maybe talk about that, but before that, remind us about measles.
Sure. So measles is a viral disease.
Yeah.
It's transmitted by what we call aerosol. So aerosols are very interesting because it's not just droplets. So you've seen that picture of the person sneezing with those giant gobs of droplets.
Yeah, we saw a lot of those during COVID.
Yes.
Yeah.
Well, this is even more insidious because measles exists in the lower airway. It grows in the respiratory tract and it is emitted by the airway. But these exist in very, very small micro droplets, less than 5 microns in fact.
Right.
And so because they're so small, they can drift in the air with Brownian motion. And they can sit in the air for up to 2 hours. And we know that because one of my colleagues, when I was at CDC, investigated a case where there had been a school blood drive, a high school blood drive. So everybody got blood drawn because they all wanted to give blood. And the next few days, there was a measles outbreak.
Wow.
So they were able to determine who was going to get infected based on their antibody levels in that pre-drawn blood.
Interesting.
And he actually established the protective titer. But he was also able to establish the fact that the kids who got infected not only had lower or no protective titers, but some of them got infected even if they hadn't been in the room with the infected person for up to 2 hours after that person had left the room.
Okay.
So you can get, it's highly infectious. And I didn't have time to talk about this today. It is probably the most infectious disease that we know of. And I say probably because if I don't say probably, a new scarier disease will show up. But it causes pneumonia. It can cause diarrheal disease. And most people, and children in particular, die from just measles pneumonia and diarrheal disease. And they mostly die in the developing world where their nutrition may be poor.
And what's the mortality rate?
The mortality rate is about 1 in 1,000. And that really will occur primarily in children who are malnourished and in children under 5. So this is really a disease of young children, children living in developing settings, and elderly individuals who might not be immune at this point or who are immunocompromised.
But pneumonia, and then there's a neurological presentation.
Yes, so you can have a neurological presentation about 1 in 1,000. That generally doesn't lead to death, but you can be severely neurologically damaged after that. So the death really comes from the pneumonia. And there's also a very rare, about 1 in a million opportunity to get a very terrible neurologic complication called subacute sclerosing panencephalitis, where you essentially have necrosis of the brain. And that is essentially almost 100% fatal. Now that doesn't occur when you get vaccinated, but it does occur from the disease itself. And we've seen that plummet since we've had such good coverage for vaccines.
I think there was actually a case of measles on the first season of the TV show that has now captured everyone's attention, the medical drama The Pit.
Haven't watched it
which
yet.
just won an award, I think, last weekend. But I think the writers there were looking for topical cases, of course, and I think that may be one of the few representations sort of in the recent public domain, not thinking about the literature where we read about it or the medical textbooks, where we've all learned about a historical disease, but bringing the idea forward that this is a disease that is coming back.
Right. And we've done such a good job of essentially eliminating, and by eliminating I mean there's no endemic transmission, even though measles still exists in the world. I was on that panel in the year 2000 where we certified that the United States had eliminated measles, meaning there were no more indigenous transmissions of measles in the US. We're going to be reassessing that this coming year. And if we're fortunate, we will still have measles elimination, meaning there will be cases, but those cases will not lead to endemic disease. And so we've been very fortunate there. But that requires a very high level of immunity in the population.
What does that, give us a sense of what does that look like in a positive scenario where maybe the vaccination levels remain where they're at, and in a negative scenario where they continue to fall?
Right. It's a little bit subjective, but it has to do with things like how many cases are you seeing? What's the duration of the cases? Meaning, are they going to continue to see further outbreaks, or as we call chains of transmission? So you see secondary, tertiary, quaternary spread, et cetera. In general, when you have elimination, and we've only really done it one time in 2000, what we saw was very few cases, first of all. And it's very easy to diagnose measles. So you really, once you see a case, you're pretty likely to identify it at the federal level. But then leading only maybe to one generation, or at most 2 generations of transmission that then stop because you've got so much immunity. And then you look at the genotype. Are there multiple genotypes spreading, or is there one major genotype that's been seen all around the country? So there's a lot of different factors
that goes into it. But in a world where maybe fewer people are vaccinating against measles, and we start to get back to the point where it's endemic, what does that world look like?
So Nathan Lowe here at Stanford, and Matthew Kang from Epidemiology and Population Health and Peter Hotez from Baylor wrote a paper in April modeling that exact question. So what happens to measles, rubella or German measles, polio, and diphtheria with current vaccination levels, with improved vaccination levels, and with decreasing vaccination levels down to 50% reductions over the next 25 years. And what we found was that even with current vaccination levels against measles, because it is the canary in the coal mine, it's the most infectious, we may likely see endemic measles come back in 5 years, with almost 1 million cases of measles in the next 25. So pretty significant. Remember, 1 in 1,000 deaths, but if you've got 25, if you've got millions of cases, 50, we estimated about 50 million cases. 1 in 1,000 deaths, that's a lot of people.
That's a lot.
And so and that's with current levels. And so what we saw was that even with a small increase in vaccine coverage in the U.S., we would actually really reduce those risks and actually probably maintain our elimination status in the United States.
And this is something I think that many of us really had reinforced during the COVID pandemic, of course, the idea of the dynamics of an outbreak and the idea that of the immunity. And you talked about it at the beginning, of course, of ring fencing, but that's also present in a population, that it might not take a big change to really have a very big positive effect, but the mirror image of that is also true, right?
Right. Well, we also, and actually I was mentioning earlier that as I was leaving my home this morning, I heard on NPR Nathan Lowe on the radio. I said, wow, that's Nathan. What's he doing? Talking about a recent paper that we just published in JAMA. I think it was last week. I can't keep up anymore. We've been trying to churn out the data as fast as we can. Talking about the vaccine exemption rate in the United States. And so let me talk a little bit about that. So in the US, there are opportunities to get an exemption from vaccination for your child to go to school. Now in California, you can only have a medical reason for that. That happened after the 2014 Disneyland outbreak. And in this state, it's not legal to have anything other than medical exemptions. And that level has been stable across many years. And what Nathan and Matthew and I and others did is we looked at over 3,000 counties in the US and looked at the vaccination exemption rate from 2021 to 2024. Now, our medical exemption rates stayed stable, which they should, because medical conditions rates don't really change. But overall, there are only 5 states that really have only vaccine medical exemption only. Most of
non-medical reasons for exemption.
Medical only, right. So the other states allow for non-medical exemptions. So for example, it used to be in California, all you needed to do was to write on a scrap of paper, I don't believe in vaccines, and that counted. Some people claim philosophical objections, which can make sense, I suppose. But some people claimed religious exemptions. Now, there is no religion that I know of that bans vaccines. And so that is, probably considered more of a philosophical objection. But the point was, of the paper is that we saw in a 3-year period from 2021 to 2024 a 5-fold rise in non-medical exemption rates across the country. Now that doesn't mean that it was like regional rates would vary, right? California had none because we can't. But some areas had a higher rate than others. And so that meant that from 2021 to 2024, we had a rate of 0.6% non-medical exemptions to 3.1%. And now you might think that's a very low number.
It's a big increase.
But it's a big increase, and it looks like we can continue to move in that direction. And remember, with measles, you need to have about 95% of the people vaccinated in order to prevent ongoing transmission. So every percentage really counts.
I think that's one of the really unique things that you as infectious diseases physicians, your community, have to deal with. It is certainly true that behavior in a given group is also sort of mirrored in your friend group. If you're in a group that exercises a lot, maybe you're more likely to exercise. If you're in a group that likes to drink wine, maybe you're more likely to drink wine. But it's not quite the same really as the transmission of a pathogen, which is where quite literally whether you choose to protect yourself can affect whether your neighbor is susceptible for, at risk of, and suffers from a given disease. How do you wrestle with that question? Because there's a civil liberties versus kind of herd immunity sort of question. And we all had it in COVID. You were you were deeply in the middle of Stanford's response and the national response in COVID. How do you wrestle with that?
Well, first of all, I'm not an ethicist. So one of the things that we do try to do with this question is we bring in ethicists. They really need to sit at the table, and we need to bring in our public stakeholders as well. Now, let me back up before I answer that question. I really don't blame people for questioning. That is normal. We should be questioning. We've all had children, I think many of us have, and we've all had to make our own health decisions or our own daily decisions. And there's so much data out there now, and we have done such a good job of being a healthy population. The average age of life expectancy for women now is close to 80, right? And for men is in the high 70s. We've done an amazing job. And so now we're really finessing that. How can I do better? How can I stay healthier longer for that long age? And so people are starting to wonder, well, gee, if I do this thing to my child, what's the long-term impact here? So I don't blame them for asking those questions. But I do want to make sure we have the proper answers for them. And if we don't have the answers, we need to try to seek them out. And we also want to encourage people to keep asking and not think, oh, she's a pediatrician. She's going to shove those vaccines in my face. And that's really important because we continue to have the trust of our families in the most part. And so we want to make sure that people have the ability to do that. And I would say that 90% of the people that we talk to, when they ask their questions, they feel good and they say, yes, I'm going to go forward. Now, the other 10%, generally, most of them come to the conclusion that they do want to support vaccination, but then there's always a small number that don't. And, we want to be respectful of those opinions. Now, coming back to your question about the ethics, yes, that goes back to medieval times. And you know this, right? So back in the 1500s, 1600s, 1700s, especially in the 1700s, in Europe, this idea that you would make decisions. Well, first of all, we had a feudal society, so basically whatever the king or the monarch wanted just got done. There's no questions. But people were actually thinking along those quasi-democratic approaches. That is, do people have the right to make some of their own decisions? And that has come into play. Now, I think in the U.S., Philadelphia really was a center at the time. Remember, that used to be the early center of the early government. And people were thinking about how should we be addressing these issues of vaccines in particular and public health. And remember, so the extreme examples, not vaccination-wise, but just of public versus personal rights is Typhoid Mary. Typhoid Mary continued to infect people. By the way, she didn't do as terrible a job as everyone thought. I mean, she wasn't wreaking havoc on hundreds of people, but enough. And she wreaked havoc on very important people, and that was the key there. Very wealthy people got sick, and so that's what sent her off to the Rikers Island, right? So, so I do think that that came up, and they did give her a number of opportunities to do the right thing. And she persisted for whatever reason. I think she had reasons to continue to do her job and infect people that she needed to make a living by being a cook.
Yeah.
But in so doing, she killed a few people, and that did it. But we need to continue to think about that. Now, another example is during the early days of the HIV pandemic, when there were people who were HIV infected not disclosing to partners, who then, despite numerous warnings, were then eventually, unfortunately, jailed because they were deemed to be at a risk to their family members, friends, and strangers even, because some of these were sex workers, for example. So we continue to battle that. And we do that with vaccines, but it's a very, very careful approach and very thoughtful. So there is something called the VIS, or Vaccine Information Statement. This is federally mandated. Every single vaccine that every person, not just children, but every person gets, that's approved by the federal government, must be accompanied by a vaccine information statement with all the risks and benefits. And the person must read them and sign it before they get vaccinated. So that's very highly embedded in the society now. So we do that. Now, if the converse happens, people decide not to, and they send their kids to school, first of all, that's probably not going to hold water in most places. They won't be allowed to go back to school. And you're coming back to your original question, because there are people in those schools who either didn't seroconvert or, more importantly, are immunocompromised. And we do see a higher and higher number of immunocompromised children in this country where they're surviving. They're living to become adults. And we have, I would estimate, about 11 million immunocompromised people in the U.S., and that number is going to go up. Many of them are children. And these are children whose families live in fear that their child is going to be exposed to a disease that they can't protect them against.
No, it's a very serious thing, and I think builds on decades, and even millennia of experience. But there's a deeper question here beyond vaccines about trust in science.
Yes.
And I think that we live in a world of science and sort of rationality and evidence, and we set very high standards for ourselves and in our conversations. And I think we would say that in a field we don't understand, if 9,999 experts who spend their entire lives in that field believe one thing and one person believes another, then that says a lot about the likely correct answer, even though there's always going to be some skepticism. And as you've mentioned, we welcome that. But we live in an interesting moment where people can surround themselves through social media, through other information sources, with a very imbalanced view. Instead of being exposed to the 10,000 people and hearing 9,999 saying one thing, they live in that little 1.1% zone where all the people are skeptical. And I think our brains are attuned to listen to the number of people that we can have in our small group. Maybe it's 100 people, 150 that we can know well and trust. So how do we, what do we do about that?
Well, you brought this up earlier when you talked about, if you're in a particular cohort, you're more likely to mimic the behaviors or reflect those behaviors. We call that a bubble or an echo chamber. I never really thought of it that way till COVID. Because of course I thought, well, science is science, right? I know what the data is, but human behavior is a big X factor. And that's okay. Again, I deal with families and children, and my job is to work with the family to make sure the child is the healthiest, safe child in the safest environment possible. So I get it. I know how, and we've spent more and more time dealing with that in my pediatric world. And so it's interesting when you see that outside of the pediatric world in many, many other areas. But I think social media has another role to play here. And the fact is that you can expand, and AI will do this even more now with deep fakes and other things. You can expand an idea, blow it up, make it mainstream with virtually no background to support that. And there may not be any way for you to know that at all. And so I think it is dangerous, but I don't think I think, most people inherently will come back to the facts when you spend the time and use the tools and the technology that we need to use to build that. So I do think we can use, and Stanford, of course, is one of the places that does a lot of the AI. Human-centered AI is so important, and ethics in AI. And so I think this is one place where we can really start to think about how do we build better platforms of trust.
Yeah, and communication.
One of the things I was talking to some colleagues earlier from the National Academy of Medicine is we're going to try to do that work and talk about not just the data that I presented. That's all stuff that we in our field know and want to get out. But how do we move to that next level? How do we get to the point where we build more trust? I think we lost a lot of trust during COVID. For better or worse, communication was not really great. It spanned 2 administrations, federal administrations, that really shifted a lot in the way they communicated. People got confused. I think for those of us in the field, we understood what we were talking about, but didn't do a good enough job of explaining it to people. And I think that we lost a lot of confidence there. And we need to rebuild that because we need to make it clear that science is not always going to answer all your questions. There are a lot of gray zones where we need to engage community
It's a process.
involvement.
I think that's one of the things that science is our best attempt at truth. It's not something you believe in or don't.
Right.
It's a process where we all work together to try to get at truth.
Well, and I don't even know what truth means anymore, right? So truth may be very subjective, right? So that's why I think science and data are helpful. But even science and data, as you know, you can
But I think truth
cherry
is not
pick it.
subjective.
Well, I mean, real
People
truth.
have their own truths. I think that's
Right.
we've come to almost redefine the word truth as something different, as belief.
Right.
But the reality is there are things
that's a good way to put it.
There are things measurable about the world.
Absolutely. So I like that better. Yes.
Yeah,
So maybe truth is one thing, and belief system. People equate truth and belief now.
Yeah, and I think that's challenging. Talking of that, and really maybe just to sort of bring us full circle a little bit, tell us what the ACIP is, and why it's in particular has been in the news just in the last few weeks.
So the ACIP is the Advisory Committee on Immunization Practices.
Yeah.
That is it's a congressionally mandated committee of the CDC. It's an advisory committee to the CDC, and it's comprised of a number of experts in the fields of immunology, vaccinology, epidemiology, pediatrics, primary care, ethics, law, private sector, pharmaceuticals, average citizens, so citizen stakeholders. And this group is given the power to advise the CDC on specific vaccine policies. And that's been around since the 1960s, so it's been over 60 years now.
Got it.
And it has been very much involved with making and crafting vaccine policy for the United States and being a part of the process by which vaccines are funded by the federal government. And by default by the states as well. So when a vaccine goes through the FDA for licensure, it must by law go to the ACIP and then the CDC for final review and approval and clinical guidance. The CDC director can then take that data and approve it or modify it or reject it. By and large, up until last year, that process was pretty straightforward, involved lots and lots of work with lots of experts.
Well, you were on this committee.
Yes, I was on the committee.
Right.
I served on the committee as a non-voting liaison representing the American Academy of Pediatrics for 6 years.
Right.
And we were obviously able to have a seat at the table but couldn't vote, which was fine because we could give our opinion. And then in the last year I was a voting member, and 17 of us were basically removed. Now it is an at-will committee, so they could do that. But we were replaced within 48 hours by a number of individuals who I am not, it's not a subjective thing. These are absolutely people who have almost all to an individual voice significant anti-vaccine sentiments. And so the ACIP is the primary advisory body to CDC around vaccine policy and guidance in the United States. It is now, since June of 2025, made up of people who have openly disavowed vaccines in one way or another. And in doing so, this committee has now met a few times, I'd say like 3 times now, and has made they've upended the process of the vaccine approval. So they don't go by the normal metric-driven approach to calculating risk and benefit and accessibility and feasibility.
Which is to say the data from many, many trials.
Right. Data from trials, data from surveys of individuals, data from observational studies that aren't included in the FDA's data. So a very large trove of data to really inform a 360-degree view of how do we provide this vaccine or not to the entire pediatric population, to the adult population, to high-risk groups, to other groups, and how do we do that in a very, very carefully curated way so that individuals can make this decision with all the data, as much of data as possible. That really has basically gone away. So in fact, in January, just last week, the Secretary of HHS unilaterally bypassed that entire process and completely changed the immunization schedule all by himself, without any input, as far as we know, because we haven't seen any transparency, and reverted to a schedule that purportedly mirrors the schedule of Denmark for reasons that we don't really understand. And so has bypassed the whole process, and we don't really know at this point. The next ACIP meeting will be in February. We don't know whether the ACIP is even relevant anymore in decision making around vaccines.
And I think I saw one graph that it moved us from one of the more comprehensive approaches to vaccination to among the least among peer countries. I mean, there was a lot of news stories about Denmark, but if you look at other peer countries, we now lag much further behind in terms of the recommended vaccination schedule. So vaccination schedules vary again from country to country, and even within the U.S., each state has a different way that they interpret the vaccine policies, although they're generally pretty rigorous. But it's really unfortunate to just take one slice of the entire social safety net and health safety net of a country, that is vaccines, and pull it out and mimic it without taking into account the rest of that country's social and political structure. So for example, Denmark is a country of 6 million people. It's very small. They have an incredibly rigid and fully supportive socialized medicine structure where they provide health care for their entire population. They track the health of virtually the entire population over their lifetime. And to just take one piece of it is really not going to work in our very highly fractured and fragmented healthcare system in the United States. Just to be clear though, there are changes in recommendations, but the vaccine schedule as it currently exists is still available for those people who might be worried.
At least for the time being, and again, we're talking in real time here. Some of us knew this was coming. We didn't know what it would look like. And so we don't really know what might change in the future. We think there will be more changes, but at least for now, the vaccines will still be available if you want them, and apparently will still be paid for if you want them. Now, the devil is in the details there, because if you don't have access to a vaccine that is quote unquote available, if your provider can't carry them because they're too expensive now for them to carry, if you don't know they're available, if you can't get to a provider because practices are closing in the country now, or the provider can't afford the vaccines to stockpile them because they're expensive. If you no longer have health care insurance and therefore may not be able to get there, or if it is provided free by the government but it takes a lot of paperwork and you have to go in and get a letter from your physician. Those are all what we used to call for HIV prevention the cascade. So in theory you have some availability. For example, with HIV prevention, when I was working in that field, of maybe 100%, but actually when you looked at the cascade of all the steps it took to get that therapy, you wound up at a 10 to 20 to 30% uptake rate, because not because the person didn't want them, but because
there were so many
systematic barriers were in place. That's assuming that people want them. And so that's the other piece. So again, I am still optimistic.
Well, I'm curious about, really just in closing, how do you think this plays out over the next few years?
Well, I believe in our American system. We're all a nation of immigrants. We came from other places, because we didn't want tyranny, because we wanted to make our own decisions. And I think that's unique in many countries, not all, but we are used to fighting for what we want. In many places, they've never had that. They've always had to listen to a very hierarchical structure. But here in the U.S., we demand to have our rights. And they may be at risk at one time or another over the course of our history. In fact, they have been tested many, many times over, and will continue to be tested. But we as a people really believe that when we want our rights, that we need to fight for them. And I do think that people have learned how to do that. And so the way we are doing that for vaccines in particular is by using our medical societies. These are, coming back to what you said, are experts and are trusted experts. So most of us are still trusted within our fields. We need to do a better job of communicating that to our public, and how we do that is going to be very important in the coming years.
Yeah, I think it's going to be vital. And I mean, thinking about our conversation has ranged from millennia through smallpox, measles, global health, and some really important and very current topics. Bonnie, you were the chair here, interim, just before me, of the Department of Medicine, and I'm very grateful personally to you for everything you did.
It's such a pleasure. What a wonderful department. You have such amazing people, leadership, and just thankful to you for taking on this job, because you've really done, just in the short time you've been here, you've really made a big difference already. Well,
it's been my privilege and pleasure, and it's been so nice to have you here, back to the department, and here on The Future of Medicine. Thanks for joining me today.
Thanks, it's been great.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.